Hello, I'm Barbara Dodson from the Department of Anesthesia. This presentation has been developed in coordination with the Operative Invasive Task Force for the University of California, San Francisco Medical Center as part of a Joint Commission mandated competency-based educational program for healthcare professionals involved in the delivery of sedation. In response to new Joint Commission standards, the Medical Center has developed new sedation guidelines which address where, how, and by whom sedation may be administered, including new requirements for assessment and documentation. How competency for administration of sedation and analgesia will be determined, and as an ongoing data-driven evaluation of the sedation process, how outcome indicators will be measured and reported. And the purpose of this presentation is to review the minimum requirements for delivery of sedation for non-anesthesiologists, review drugs commonly used for sedation and analgesia for diagnostic and therapeutic procedures, and review the airway management for patients undergoing these procedures, which require minimum to moderate sedation. The UCSF guidelines that we're presenting today outline the minimum requirements for delivery of moderate to deep sedation during diagnostic and therapeutic procedures for adults and pediatric population in any setting, for any purpose, and by any route. It should be noted that the guidelines do not apply to the use of analgesics or sedatives for the intent of providing analgesia or to allay anxiety, such as in dressing change. That is, what is now defined as minimum sedation. Or for anesthesia, including monitored anesthesia care, as provided by a member of the anesthesia care team. Now, the changes that the Joint Commission have made reflect the development of new diagnostic and therapeutic processes. In this, the lines have been blurred from invasive procedures into those procedures traditionally performed in the operative setting. Because of this, the Joint Commission has now adopted standards across all the continuum. In the same way, the Joint Commission has recognized that sedation is also part of a continuum from minimum sedation to general anesthesia. Because of this adoption of the continuum of sedation, the definitions have been adjusted. Minimum sedation, which I spoke of just ahead, is in that situation where patients respond normally to verbal commands and ventilatory and cardiac functions are unaffected. Again, this would be a situation where the drugs are given to allay anxiety. Moderate sedation is what used to be called conscious sedation. And under moderate sedation, patients respond purposely to verbal commands, and spontaneous ventilation is adequate without supplementation from a healthcare professional. Deep sedation, however, is a state in which patients are not easily arousable. They may follow commands, but it requires repeated and painful stimulation. And under this condition, there's an increased probability of respiratory and hemodynamic compromise, as well as an increasing loss of protective reflexes. Anesthesia is a state in which, for general anesthesia, patients are not easily arousable by painful stimulation. There's a good probability of respiratory or potential for respiratory or hemodynamic compromise. Airway reflexes are decreased. And under this is defined as both general, regional, and major and spinal anesthesia. Now, who can administer sedation? It must be by a licensed practitioner, an MD, or an RN. The Joint Commission has now defined that the healthcare individuals must have competency-based training in which there's privileging and recredentialing for physicians as part of their staff recredentialing process, and nurses to undergo competency evaluation. It should be remembered, however, that the ultimate responsibility for procedural sedation and analgesia is on the attending procedural physician. This includes, for pre-procedural assessment, consent, benefits, risk, and alternatives, for both the procedure and for sedation and analgesia, the interprocedural monitoring and medications that are delivered, and post-procedural monitoring, discharge criteria, and patient education. It's important to remember that this includes for sedation directed by the primary procedural physician and delivered either by nursing or physician faculty, including or residents. Now, where can sedation be administered? The Operative and Invasive Task Force has recognized very specific locations which are listed in the sedation guideline. These locations include the ambulatory and inpatient pediatric treatment areas, ambulatory care program, areas in cardiology, critical care units, the emergency department, endoscopy center, radio-oncology center, specific areas of the radiology department, labor and delivery suites, operating rooms, pain management center, and the post-anesthesia care units. However, the medical center also recognizes that it may be necessary to go and use other sites for the delivery of sedation. However, the decision to use the other sites and the responsibility is that of the attending procedural physician. And if other sites are used, they must follow the guidelines and medical staff laws with respect to equipment, adequate and competent personnel, infection control, assessment documentation, and outcome and procedural reporting as followed in the recommended areas. Now, as part of the new Joint Commission mandated competency-based education and credentialing, how is it going to be determined? Well, this is part of the new requirement which came in January of this year by the Joint Commission. And in this, we'll have nursing and physician education, which will go over the guidelines and requirements for assessment, documentation, monitoring requirements, medication administration, and airway management. As mentioned, the sedation process will be data-driven, outcome analyzed. And in this, the Operative and Invasive Task Force has defined very specific sedation analgesia outcomes that will be monitored. These indicators must be measured and reported as a quality improvement process of the individual departments who deliver the sedation. And these now will go and follow procedural requirements, the same as was originally used for operative procedures under general anesthesia. This is part of the continuum. As those standards were previously set up for operative procedures under general anesthesia, they now apply to non-invasive and invasive procedures under sedation. This includes medical staff assessment of the patient, risk, benefits, and alternatives as part of the informed consent process, and development of plan of care and documentation before the procedure, including procedural plan, sedation analgesia plan, nursing plan of care where appropriate, and post-procedural plan of care, including discharge. Now, what are some of the essential requirements for patients that will receive analgesia? The guidelines list very specific requirements with regard to personnel, equipment, pre-procedural evaluation, including evaluation and documentation of NPO status, monitoring requirements during the procedure, documentation, recovery and discharge criteria, medications given, adverse event reporting system. Now let's go into some of the individual items listed. With respect to personnel, again, as we've mentioned, must be done by a licensed practitioner, MD or RN. Must have competency-based credentialing. One of the things that is recognized that there must be sufficient staff to go and give sedation during procedure. And this is defined as an individual other than the practitioner performing the procedure needs to be presented to monitor the patient throughout the procedure performed with sedation and analgesia. We do recognize in some diagnostic and therapeutic procedures the individual may assist with minor or interruptible tasks. However, because of the importance of sedation and analgesia of the patient, it is recognized that a second nurse or associate may be required in some procedures to assist the physician where those procedures are complicated either by severity of the patient's illness or complex requirements associated with advanced diagnostic or therapeutic procedures. In other words, a separate individual for sedation in addition to another individual to assist the practitioner. The guidelines also defines minimum equipment necessary for deliverance of sedation. These include oxygen source, supplemental administration devices, such as nasal cannula and face mask, resuscitation bags, self-inflating or Jackson Reese, functioning suction source, emergency supplies and drugs readily available, emergency airway equipment, and a defined plan for obtaining assistance in airway management in the event of an airway emergency. We'll go into several of these in more detail later. Included in the equipment, it's important to have a telephone present at the site. The electrical source should be present. There should be backup power capability, and it's suggested also to have a flashlight. Pulse oximetry is required as minimum equipment for any sedation process. Non-invasive blood pressure monitoring equipment, electrocardiographic capability must be immediately available. Must be intravenous access, and the presence of antagonistic agents such as naloxone and flumazenil in. Now, there have been changes with regard to the pre-procedural physical examination. Again, this recognizes the continuum of the standards from those for the traditional operating room procedures now into procedures in the non-traditional settings. This includes a current pre-procedural history and physical, which we'll detail in a second, initial nursing assessment, also immediate reevaluation of the patient prior to the procedure as far as the appropriateness of the plan for sedation or analgesia. Again, pre-procedural assessment of the physical classification. Any change in advance directives must be specifically addressed, particularly the DNR orders if they are changed or on hold. There must be a quantitative pain assessment documented. Now, as I mentioned, there are very specific qualities that must be in the H&P. This includes the patient history, a review of system, list of any allergies, medications used by the patient. There also must be assessment of the airway, pulmonary, and cardiovascular system, in addition to the system or body part undergoing the interventional procedure. There must be a pre-procedural documentation of vital signs and the modified Aldrete score. I'll go into the modified Aldrete score in a few minutes. There must be documentation of NPO status, and if NPO status is not followed, there must be documentation for exception to it. Assignment of the ASA classification by the primary procedural physician. I'll go over that in more detail in a second. For come-and-go procedures, there needs to be verification of a responsible post-procedural adult for accompanying the patient, and there must be transportation arranged prior to the procedure. Discharge instructions and education should be provided prior to sedation and the procedure. With regards to the NPO status, the standards that have been adopted by the medical center is that for patients greater than 2 years old, they need to be NPO for solids for a minimum of 6 hours pre-procedural. Clear liquids may be given up to 4 hours pre-procedure, and they must be, however, NPO including clear liquids for 4 hours prior to the procedure. In the pediatric population under 2 years old, NPO also for 6 hours pre-procedure. They may be allowed to have clear liquids up to 2 hours prior to procedure, and NPO for clear liquids within 2 hours of the procedure. Again, if for some reason, for example, the emergency nature of procedure, that NPO status requirements are not able to be obtained, this must be documented. There must be a formal documentation of pain assessment. The Joint Commission feels very strongly about this and now feels that pain is the fifth vital sign. It is an important component of the monitoring of the process and needs to be documented pre and post procedure with responds to intensity and quality. Now, one of the things that has been recognized is the need for standardization in recording the patient's physical status. This is needed as part of the pre-sedation and analgesia assessment, the immediate evaluation of the patient prior to the procedure, and to be used in identifying and measurement of high-risk populations procedures as part of the ongoing quality improvement process. What the medical center has adopted as the classification system is the well-known American Society of Anesthesiology Physical Classification System, which ranks physical class of patients from 1 to 5. ASA1 or P1 is a healthy individual, no systemic disease, no extremes of age, and is undergoing elective procedures. 2 is an individual with one system, well-controlled disease that does not affect daily activity. An example of this would be well-controlled hypertension. ASA3 represents an individual who has multi-system disease, a well-controlled major disease system that limits their daily activity without immediate cause of death. An example of this would be angina, diabetes, requiring insulin. ASA4 is an individual with severe or incapacitating disease, poorly controlled, or at end stage, which is at risk of death due to organ failure. And 5 is a patient in imminent danger of death for whom the procedure is deemed a last resort for preserving life. We recognize that this is a continuum, and sometimes it is not a cut and dried procedure as far as what class is in, but best medical judgment must be made in classifying the patient. There is also a modifier for emergencies, and this can be added to any of the classifications, and it is in response to any patient for whom an emergency procedure is required. Now, we mentioned the modified Aldrete score. Now, this has been adopted as the approved organization recovery criteria in an attempt to be able to quantify recovery criteria. I realize this is difficult to read, but what it does is it scores the patient with respect to level of consciousness, their physical activity, hemodynamic stability, respiratory stability, oxygen saturation status, pain assessment, and emetic symptoms. The guidelines require an assessment prior to the procedure and at the end of the procedure as part of the discharge criteria. Now, as I had mentioned before, there's very specific pre-procedural documentation requirements. We had addressed the history and physical. Again, very importantly, informed consent and documentation, witnessed and signed, and consent for procedure and sedation. This also should include the risk, benefits, and alternative statement. In addition to the plan for the procedure, there should be a written plan for sedation, analgesia, and recovery. Now, in the plan of sedation and analgesia and the level of post-procedural monitoring recovery must be identified prior to the sedation. In other words, patients must be, the plan for their care must be set up according to specific criteria. And this includes physical status of the patient, the level to plan sedation, and the complexity of the procedure, diagnostic and therapeutic, including the length of procedure. And there must be some documentation that these points were taken into consideration of the plan. The sedation guidelines has very specific requirements for monitoring during procedures. And these are to ensure the adequacy of oxygenation, ventilation, and cardiovascular function. These include blood pressure measurement every 5 minutes, continuous measurement of pulse oximetry to assess oxygenation, continuous physical assessment of ventilatory adequacy. This includes such measures as respiratory rate, respiratory effort, and when appropriate, measurement of end-tidal CO2. ECG monitoring in select patients as appropriate for their underlying physical status or the procedure, but it should always be available. And there must also be an assessment to responsiveness to verbal and physical stimulus every 5 minutes. The documentation requires the use of a sedation record, which meets the sedation guidelines requirements that we were talking about. There is an example of the sedation guideline at the following site. Minimum documentation includes vital signs, pulse, heart rate, saturation as measured by pulse oximetry, and respiratory rate, as well as responsiveness. Although they are assessed every 5 minutes, they need to be documented every 15 minutes for moderate sedation. Also must be documented the time, dosage, and route of any medication given. And special note must be made on the record with regards to any complications, abnormal ECG rhythms, changes in mean arterial blood pressure below 30% of baseline, oxygen saturation less than 95%, or heart rate or respiratory rate less than 10 per minute. The Joint Commission has very specific guidelines with regard to the recording of the diagnosis and procedures. There must be a pre-procedural diagnosis recorded before the procedure, similar to that done for surgical procedures. There must be a procedural note written and dictated immediately after the procedure. If dictated, there must be included within the chart a handwritten note which includes the following items, including the name of the primary procedural physician, any assistants that may have been involved in the procedure, findings of the procedure, technical procedure used, specimens, if any, that were removed, and the post-procedural diagnosis. In the post-procedural documentation also must include vital signs, including pain assessment, and that's a quantified pain assessment, level of consciousness, again, medications, fluid, blood administered during the procedure, any unusual events that occurred, as well as their management, and change on the advanced directive status. The procedural note needs to be authenticated, that means signed, and there must be discharge criteria for the procedural recovery area. And again, this is discharge criteria is documented using the modified Aldrete score and identification of the licensed independent practitioner in charge of the discharge. The patients also must be monitored in the post-procedural time. And again, they must be monitored for such things as physical and mental status, the status of the procedure, i.e. wounds, if applicable, medications given during the post-procedural period, including medications, fluid, and blood, any impairments or functional status changes that occur, pain assessment, very important during the post-procedural time, again, changes in advanced directive, and any unusual events or complications. There also must be an evidence that all played a role in any decision-making involving the patient. Now, with the documentation, this must include the modified Aldrete score, including pain, should be continued into the post-recovery period. Now, it is important to realize that this is minimum documentation. Additional requirements for recovery criteria may be developed in each department based on other criteria unique to their populations or for the procedures which are performed. These may be stratified according to patient's physical status as quantified by the ASA classification system, the complexity of the procedures, or the degree of the sedation or analgesia given. Outpatient criteria should include documentation of recovery to baseline level of care, accompaniment of responsible adult, the ability of the patient to take PO fluids and to void, minimum nausea, dizziness, or pain, recover to baseline ambulation as appropriate, and family documentation that the family and patient comprehend discharge instructions. Now, as we mentioned, it's very important that the sedation analgesia process be followed by outcome indicators. The medical center has defined specific outcome indicators which are to be collected and monitored for the stability of the process and identification of any trends. This includes the important sentinel event procedure followed, which is already documented by the medical center, and the use of these indicators for quality improvement activities. These indicators are also used for identification and measurement of high-risk populations and procedures, both as far as indication, management of the process, and outcomes. The indicators which have been defined include the use of a reversal agent, naloxone or flumazenil. It is felt that reversal agent is not a routine or customary component to minimum moderate sedation and must be followed. New assisted ventilation. This includes either mask ventilation or the need for intratracheal intubation. Increased level of care beyond that what was planned. And this would be unanticipated hospital observation, admission, or transferred to a higher level of monitoring or critical care bed as a result of pre-procedural changes in status that were unanticipated. Cases in which oxygen saturation is decreased to levels indicative of respiratory compromise. This is defined as a pulse oximetry reading of less than 90 for adults, 86 for neonates for greater than 5 minutes, including during the recovery period, or at 80% at any time, or in that patient population that does not, whose baseline is below this, any significant clinical change from the baseline. Also need to monitor process indicators with response to hemodynamic instability that requires intervention. Hemodynamic instability has been defined as a change of 30% below baseline, either in blood pressure or heart rate, or the occurrence of any new dysrhythmia. Other monitors include failed sedation, analgesia. In such a case that a procedure is not completed because the patient was unable to be adequately sedated as planned, or that the decision has been made to progress to monitoring anesthesia care and all general anesthesia. Any unplanned progression from minimum to moderate sedation, unplanned deep sedation, and finally, any AMA discharges against medical advice. And this refers for all patients who receive sedation who left without a physician clearance for discharge or left unaccompanied by a responsible adult. And what do we need from you with regards to the outcome indicators? For practitioners, we need compliance with the guideline requirements for assessment, documentation, and monitoring. For departments, we need timely sedation data collection, analysis, and submission. And the review of the aggregate data in department and staff meetings and use of this data for development of improvement activities as indicated. I'd like to now move on to the medication module. And in this, I will review drugs commonly used for sedation and analgesia. It's important to remember when we're talking about sedation endpoints that the drugs discussed are used both for moderate and deep sedation, and it's a matter of degree. The difference between the two, between moderate and deep, however, reflect not only the level of sedation, but also other physiological changes that may occur. And this includes changes in respiration or the cardiovascular system. It should be noted that credentialing for deep sedation with general anesthesia rescue requires additional training. Now, what are some of the commonly used medications used in the sedation process? The first family is the benzodiazepines, of which diazepam, lorazepam, and midazolam are most commonly used. Opiates, morphine and fentanyl, as well as meperidine, and some of the other classifications, droperidol, in some circumstances chlorhydrate. Now, in the guidelines, there is listed specific recommended dosing for these agents and frequency for moderate sedation. And also in the guidelines, specific dosing, maximum doses, and frequency for the pediatric and neonatal population. It should be mentioned that these doses should also reflect clinical judgment. Certain patients are going to require extra consideration. This includes the elderly or frail individual, and it's suggested that you should start lower doses and go much slower. Pediatric population, may actually show paradoxical excitation with increasing levels of these medications. Patients with hepatic function have less protein binding, therefore will have higher drug levels for the same drug doses, and will also have greater accumulation because of slower metabolism. This can also be seen with patients with renal dysfunction because of slower metabolism and excretion. Patients taking other drugs with CNS effects can also affect the total sedation. This includes prescription drugs, over-the-counter drugs, including herbal drugs and recreational drugs. One should always consider alcohol in this. It is important to remember that a high percentage, much higher than appreciated, of the elderly population does abuse alcohol and has been estimated about 10%. So it's very important as part of the history and physical to get the history of the drugs. Now, one consideration that should be made is that in the presence of significant respiratory and or cardiovascular changes, where the underlying cause is not easily identified or remedied, it may be the safest thing to abort the procedure and reschedule it with additional support. Now, as I mentioned, one of the things that can be seen is this disinhibition or paradoxical excitation. It's a relatively rare phenomenon whose mechanism is unknown. And what you will see in this patient population is as you increase the sedation, the medications, instead of seeing sedation, you start seeing agitation, increased anger, hostility. Patients may get talkative, restless, euphoric. Now, there are some patient population that has a higher risk factor for this. Seems to be in the pediatric and geriatric population, and also in those patients that have pre-existing psychiatric illnesses. One should also be aware of potentials for drug-drug interactions, both pharmacodynamically with other CNS depressants, including alcohol. One should also keep aware of what the total amount of local anesthetic drug given, because you can have a cumulative effect increasing sedation with these medications. Pharmacokinetics. How is the patient metabolizing the drug? How is the patient's cytochrome 450 system working? In some patients, because of medication, you have enzyme inductions, and others you have enzymes inhibition. So there may be a difference in the length of time that the drugs will be used in these patients. A special population is the gravid patient. Additional guidelines should be used with the pregnant patient. In this population, oxygen saturation should be kept higher than 95%, and mean arterial pressure should be greater than 65 millimeters of mercury. This is to ensure adequate oxygenation and cardiovascular support of the fetus. In patients greater than 24 weeks pregnant, they should be positioned on left side or left uterine displacement to avoid venal cable compression. It's important to remember that opiates are safe in the pregnant population. The use of fetal heart rate monitoring should be determined on an individual basis. Importantly, obstetrical consultation is strongly recommended prior to any procedure, particularly those requiring sedation. Now I'd like to speak for a few minutes about the specific classes. And first, the benzodiazepines. This class of drugs works at potentiating the GABA effect, where GABA is an inhibitory neurotransmitter. Its effects are dose-related and basically has CNS depression at all levels, with a dose dependency going from mild sedation through hypnosis to coma. Onset and duration is rather quick. For PO, it can be under 10 minutes. Diazepam has a very fast onset for PO, from 1 to 5 minutes. Duration varies from 2 to 10 hours, particularly with lorazepam. Therefore, recovery can be prolonged, particularly in the elderly population. There are a number of different formularies available for both diazepam, lorazepam, and midazolam. It's important to remember the injectable, which is the most commonly used in the sedation process, comes in different strengths, and care should be used to make sure what dose is being administered. Metabolism and elimination of benzodiazepines are through hepatic renal excretion. And as I mentioned before, patients with hepatic renal dysfunction should have special consideration. Adverse effects include hypotension, ataxia, vertigo, pain at injection site, particularly with Valium, paradoxical disinhibition and excitation, and then up to apnea and cardiac arrest. There are certain patients for which benzodiazepines are contraindicated. They obviously should be avoided in patients with known hypersensitivity. In the comatose patient or in the patient with pre-existing CNS or respiratory depression, they should be avoided or used with great caution. Patients with narrow angle glaucoma is felt to be contraindicated, as well as patients with severe pain or severe hypotension or shock. Now, what are some of the signs of improper dosing? As I'd mentioned, you can see hypoxia, agitation, increase in involuntary movement, hyperactivity, or combativeness. How does one treat an overdose? As I'll talk about in a minute, there's the specific antagonist flumazenil. But for the most part, overdoses should be treated with supportive care, including fluid, oxygenation, and respiratory and cardiac monitoring and support as necessary. Now, the opiates. Mechanism of actions for the opiates is to bind at the opiate receptor within the CNS. There's also an inhibition of ascending pathways through the spinal cord. Opiates will also alter perception in response to pain. These frequencies, the patient say they feel the pain, they just don't care as much. Onset and duration varies between the drugs, with morphine and meperidine having onset of 5 minutes, with peak in 20, and duration to 1 to 5 hours. It's important to remember that the peak is quite long, and care should be given not to overdose in that time frame. Fentanyl has a faster onset, and it peaks within 5 minutes, but a shorter duration. Again, metabolism and elimination is hepatic and renal with the same caveats. Adverse effects in overdose include hypotension, particularly seen with rapid IV administration. Occasionally bradycardia will be seen, dizziness, nausea and vomiting, and going through to respiratory depression or potential for cardiac arrest. It should be noted that nausea and vomiting is an adverse effect and not an allergy. Should be noted also that pyridine that has an active metabolite, which is seizurogenic. Treatments of overdoses of narcotics can be treated either with reversal agents, naloxone, and supportive care. Because, as I'll mention, the reversal drugs have a shorter duration of action than the narcotics, an extended recovery period is necessary. Droperidol alters another class of drug, which alters the activity of the dopamine receptor in the CNS, which produces sedation. It has a strong antiemetic effect. However, we should note that it has no analgesic properties. Onset and duration is fairly quick, 3 to 10 minutes, and has a variable duration of action. With most people, it's 2 to 4 hours. However, particularly in the older individual, it can last up to 24 hours. Again, a hepatic and renal excretion for metabolism and elimination. Adverse effect in overdoses include cardiovascular, and this can be either hypertension or tachycardia. Some patients have hallucination. Other patients will also have CNS changes, which may manifest itself as an apparent outward calm, but actually a locked-in phenomenon. There's also the potential for extrapyramidal symptoms, and these appear to be worse in the elderly population. Treatment is by supportive care. There is no known antagonist. Chlorhydrate. Mechanism of action that is by mild cerebral depression. It also has minimum analgesia properties. The guidelines recognize specific use in the pediatric population and its use in pulmonary function test and EEG testing. Onset is fairly slow, between 30 minutes to an hour, and is fairly long-lasting. Again, hepatic and renal metabolism and excretion. Now I'd like to speak a little bit about the sedation antagonists, that is, the reversal agents. There are two presently in use. One is flumazenil, which is a benzodiazepine antagonist, and the other naloxone, an opiate antagonist. There are two major problems with their use. As I'd mentioned, first, they have a shorter duration of action than the drugs they reverse. Therefore, you can have resedation or renarcotization. The second thing is you can get over-antagonism. And in this case, you could end up with seizures, particularly flumazenil, and no analgesia at all with using an opiate antagonist. This can result in severe pain, increased sympathetic stimuli, including going to cardiac arrest and pulmonary edema. Flumazenil has a mechanism of action which competitively antagonizes the benzodiazepines. It is important to remember, though, that although it does reverse CNS depression, it has no effect on respiratory or cardiac depression. Again, a rapid onset, but a short duration of action, and repeated administrations may be necessary. It has no effect for reversal of narcotics, ethanol, or barbiturates. It does come with certain warnings and precautions. As I had mentioned, there's a high-risk procedure, particularly in a high-risk population. This includes patients that have been on long-term sedation by benzodiazepine because of the upregulation of the receptors. Patients on tricyclic antidepressants are also prone to seizures with reversal agent flumazenil, as well as patients on other concurrent sedatives by inducing hypnotic drug withdrawal. And also in that patient population with pre-existing myotonic jerking or seizure activity, it does lower the seizure threshold. As I had mentioned, it does not reverse respiratory depression or hyperventilation or cardiac depression. Naloxone, again, works by competition at the site of the opiate receptors, with displacing the opiate on the receptor itself. It reverses both the CNS effects and will oppose the respiratory depression. Onset is rapid, usually less than 2 minutes, but has a short duration. Therefore, repeated doses should be necessary. I would now like to go and address airway support. And the purpose of this part of the program is to review airway management for patients undergoing procedures requiring minimum to moderate sedation. Now, what is the underlying problem with the airway in this population? In the setting of sedation, it turns out that respiratory compromise is a major portion of the procedural complications that we see. Some of it is secondary to primary respiratory depression from oversedation. Others are ventilatory failure because of the decrease of the reflexes of the airway, leading to partial or complete airway obstruction. Therefore, it is important in this population to have continual and prompt assessment intervention early in any problems, and you appropriately use equipment for both monitoring and airway support. One of the ways to ascertain the airway is by an ongoing view of the system. And then in this assessment, one should look at the character of the respirations in the individual. What is the rate? Is it slow? Is it fast? Is it normal? What is the depth? Are we looking at shallow? Are we looking at deep? Is it sound? Is it stertorous? Does it sound like there's upper respiratory obstruction going on? Is there movement? Is the chest actually moving? And if the chest is moving, is there paradoxical movement? Is there actual air movement? Now, with the increased level of sedation, as we were saying, you can get hyperventilation by respiratory depression and airway obstruction. Now, how can we go and measure adequacy of oxygenation and ventilation? Some of it can be done by monitoring. This includes pulse oximetry and the use of end-tidal CO2. But more importantly, one should always keep an eye on the patient. Observe the patient. Observe the character of the respirations. Look at the color of the mucous membranes and nail bed to assure adequate ventilation. Pulse oximetry has been a real addition to monitoring airway. However, it's important to remember that it is a measurement of oxygenation, not ventilation. And patients can have significant hypercarbia before you can see a change and oxygenation. In normal individuals with normal cardiac output, you will have to have a PaCO2 in the 80s before you will see a change in oxygenation as measured by pulse oximetry. Now, when you look up and you see a decrease in the pulse oximetry, why is that occurring? The first and foremost should be assuming that you have inadequate oxygenation. This may be by inadequate ventilation. Again, assess the patient. Or there may be a change in the source of oxygen supply or delivery. Has the O2 tank run out? Has it been disconnected? Is somebody standing on the line? Has the patient knocked away their nasal prongs or face mask? You also might have change in the pulse oximetry reading due to inadequate signal. This can be either by hypothermia or poor perfusion, decreasing the amount of oxygenation. And finally, movement artifact. One should always assume that first it's poor oxygenation and check the patient, and then work down for equipment problems. Now, if a patient is having airway obstruction or decrease in effort, there are certain positioning maneuvers that are very useful. This includes neck extension and chin lift. And this is a gentle extension of the head and neck with an upper displacement of the chin to move the soft tissues, which become increasingly relaxed with increasing sedation. If that is insufficient, then a jaw thrust may be necessary. And this is a two-handed maneuver which will produce a significant anterior displacement of the jaw and upper airway to open the airway. It also induces a fair amount of stimulation, which may increase respiratory effort by the patient. It is important to recognize that if the above is not adequate, that you may need to move to more invasive maneuvers, and you may need to utilize additional help. Now, it's important to go and have a written plan prior to any of the procedures for managing airway emergency. This includes instructions defined ahead of time for obtaining assistance in airway management and provisions for backup management, backup personnel with expertise in airway management, emergency intubation as necessary, and ACLS if necessary. Now, this personnel may include appropriate trained department personnel, which has been recognized ahead of time within each department. It may be utilizing the Code Blue team, or maybe EMS intervention. And an appropriate airway management would be to call the front desk of the operating room. This can result in a significant time delay in trying to find personnel, and personnel may not be available through the Department of Anesthesia. Therefore, this is not a recognized mechanism for obtaining airway emergency management. Now, there's some adjuncts that can be useful for patients with deeper sedation that are having airway problems. These include mechanical airways, such as the nasopharyngeal airways and the oropharyngeal airways. However, we should recognize that these have complications with their uses. Trauma can occur with their placement, either the nasal airway being placed, oral, with damage into the mouth and to the teeth. You can get bleeding with the presentation, there's particularly with the nasal airway. In patients whom the airway reflexes are not entirely gone, you may end up with gagging and vomiting, and you may induce laryngospasm. Other ways to go and assist in respiration include the use of bag mask devices. There are two types of these that are available. The first is the self-inflating or ambu bag. This has advantages and disadvantages. One advantage is it does not require an oxygen source. But it's important to remember that the ambu bag has a one-way valve. Therefore, the patient cannot get any air with their own respiratory effort, and you may be actually decreasing the availability of oxygen to the patient without actually giving breaths. Jackson-Rees circuit, the advantage of that is that you can passively deliver oxygen assisting the patient's own respiratory efforts. However, it does require an oxygen source. Of the oxygen delivery systems, they have different capacities and different percentages of O2 that can be delivered. Nasal cannula can deliver between 1 to 6 liters per minute, and it can increase inspired O2 from 25 to 40%. As the simple air mask face mask also can deliver 8 to 10 liters per minute and can increase the inspired O2 between 40 and 60%. Both the non-rebreathing mask and bag mask devices are capable of delivering very high flows, 10 to 15 liters, and can increase inspired O2 up to 100%. Now, what equipment is necessary to be on hand for airway management? And this needs to be present whenever sedation is given. This includes an oxygen source and supplemental administration devices that we've just gone over, a functioning suction source. It is important to have this set up ahead of time. This is not something that you want to try to get as a patient is actively vomiting or having airway secretions. In this, you need a dedicated wall unit with collecting canister, sufficient length of connecting tubing, a Yankar, and flexible tip suction apparatus. You need to have your emergency drugs and supply readily available, including reversal drugs, bag mask devices, which we've just spoken of, emergency airway equipment, and a defined plan, which we've discussed. In summary, we have reviewed the minimum requirements for delivering of sedation by non-anesthesiologists. We have also reviewed drugs commonly used in the sedation and analgesia process, and reviewed airway management for those patients undergoing procedures requiring minimum to moderate sedation. We hope this presentation has been useful. Thank you for your attention.